Bismillahirrahmanirrahim. This video is about rosacea, that is a disorder of epidermal appendage. Following are references for this video. The term rosacea is derived from a Latin word rosaceus that means rose colored. It is a common skin condition that causes blushing or flushing and visible blood vessels in the face. The commonly affected age group is 30 to 50 years of age, and peak incidence of this entity is between the age of 40 to 50 years. Females are more commonly affected by rosacea, but the rhinophyma, that is the advanced stage 4 of this disease, is mostly seen in males. 3% of the US population and 10% of the US fair skin population is affected by this disease. The disease is more common in Celtic person, the skin phenotype 1 and 2, and is also seen in southern Mediterraneans, but this is less common in skin phenotype 5 and 6. The Plevig and Kligman classification for rosacea has divided it into three stages. One is the flushing episode, that is also termed as pre-rosacea, and then stage 2 is persistent erythema and development of telangiectasia. Then stage 3 is pustule and papule formation. Rhinophyma is advanced lesion, and it is involvement of the nasal skin that is permanently thickened by confluent erythematous papule and prominent follicles. There are other sites of the face that are also affected, and we are going to see these lesions later. The stages progression from one stage to another doesn't always occur, and the disease may start with the stage 3 or stage 2, and stages may overlap. Both qualitative and quantitative disturbances in cathelicidin are seen in patients with rosacea. Cathelicidin is an antimicrobial peptide and is a mediator of the cutaneous innate immune response. The individual with rosacea have an increased cutaneous level of cathelicidin. This antimicrobial peptide is qualitatively different in affected individuals. It is produced by alternate processing uh, by proteases kallikrein 5, that is also termed as stratum corneum tryptic enzyme. This stratum corneum tryptic enzyme is upregulated by the activation of TLR2, toll-like receptor 2, and there are several microbial triggers are suggested that are responsible for activation of TLR2, but none is proven as yet. The injection of cathelicidin from affected individual to mice produced changes of rosacea such as inflammation and vascular dilatation. Now the clinical manifestation of the rosacea. On history, there is evidence of episodic reddening or flushing of the face in response to hot liquids, spicy food, alcohol, and exposure to sun and heat. Uh, there may be history of prior acne, but usually rosacea arises de novo. The duration of the lesions can be days, weeks, or months. The patient is concerned about the cosmetic facial appearance, and the early skin lesions are flushing or red face that are the pathognomonic of the rosacea. The tiny papule and papulopustules that are 2 to 3 millimeter in size. The pustules are often smaller in size and they are less than 1 millimeter in size, and pustules are present on the apex of the papule. They are not associated with the presence of comedones. So comedones are absent in rosacea. The late lesion are red faces and dusky red papules and nodules, and there are scattered discrete lesions and development of telangiectasia. There is marked sebaceous hyperplasia and lymphedema. This gross appearance of the rosacea is showing stage 1 or erythematous rosacea. It is the early stage and present with episodic erythema, that means flushing and blushing. This flushing and blushing is followed by persistent erythema, that is due to presence of multiple telangiectasias. These are tiny and they result in a red face. This is moderately severe rosacea in a 29-year-old female. There is persistent erythema, telangiectasia, and a red papule. There are tiny pustules also present. This is stage 2 of rosacea. This is the gross appearance of stage 2-3 rosacea. There is telangiectasia, papule, and pustule, and there is no comedone. Another gross picture of stage 2 and 3 rosacea. There is facial flushing. There is persistent erythema, presence of telangiectasia, and along with edema, and there is presence of multiple inflammatory papules and pustules. No comedone are present. Another gross appearance of papulopustular rosacea or stage 3 rosacea. In this 65-year-old female, almost entire face is involved, only sparing the upper lip and chin. There are many papules and pustules. Some are coalesced, and there is no comedone. There is swelling of the cheek. So this is rosacea stage 3. Rosacea lesions are distributed symmetrically on the face. Rarely they are present on the neck, V-shaped area of the chest, back, and scalp. There are some special lesions in addition to the lesions we have discussed earlier. The phyma means a tumor or growth. So rhinophyma is enlarged nose. Metaphyma is enlarged cushion-like swelling of the forehead. Blepharophyma is swelling of the eyelid. Autophyma is cauliflower-like swelling of the earlobe. Gnatophyma is swelling of the chin, and these lesions are characterized by marked sebaceous gland hyperplasia, fibrosis, and this gives a soft rubber-like consistency to these regions. Eye involvement is also important. The rosacea is associated with the red eye in some cases. This is due to chronic blepharitis, conjunctivitis, and episcleritis. It is important to recognize rosacea keratitis. This is a rare condition, but if it occurs, it is associated with corneal ulcers. Here, the predominant feature of the rosacea is a soft, rubbery nose, enlarged nose. There is edema of the forehead and edema of the cheek. The papule and pustule are also present, and some crusted pustules are also present. Uh, in some cases, the changes of the rosacea are localized to uh, one cheek or localized to the nose. Here in this gross picture, the nose is affected, and this rosacea is affecting only nose. In chronic rosacea, the nasal skin become coarse in texture and result in gross thickening and hypertrophy that result in rhinophyma as is seen in this picture. This is the rosacea associated blepharitis and conjunctivitis. There is some eyelid edema also present. Microscopically, the rosacea is characterized by presence of non-specific perifollicular infiltrate that is composed of lymphocytes. It is surrounded by dermal edema and telangiectasia. Here in this picture, the lymphocytes are present around the hair follicle, and also the perivascular lymphocytic infiltrate is seen. In the pustular phase, the neutrophil may colonize the follicle and follicle rupture. Then the dermal response is granulomatous. Rhinophyma is associated with hypertrophy of sebaceous gland and follicular plugging by keratotic debris. The laboratory examination, particularly for rosacea, are none, but bacterial culture are performed to rule out S. aureus infection. The scraping of the area of the lesion uh, may show massive concurrent Demodex follicularum infestation. The rosacea should be diagnosed or differentiated from facial papules and pustules such as acne, perioral dermatitis, Staph aureus folliculitis, and Demodex follicularum infestation. In acne, there is presence of comedone, and there is wider distribution of the lesion that improves with sunlight. Perioral dermatitis occurs in female with pustules and erythema around the mouth and chin. This may be precipitated by the use of topical steroids. Some patients experience uh, premenstrual exacerbation. Treatment is to stop the steroid and use uh, tetracycline. This rosacea should be differentiated from other conditions that result in facial flushing and erythema, such as seborrheic dermatitis, prolonged use of topical glucocorticoids, systemic lupus erythematosus, and dermatomyositis. In seborrheic eczema or seborrheic dermatitis, there are no pustule and eczematous changes are present, while SLE show light sensitivity. Erythema and scarring are there, but no pustule formation is seen in systemic lupus erythematosus. Dermatomyositis is associated with periorbital and upper eyelid swelling and erythema. Rosacea has a prolonged course, and it is exacerbated by heat, exercise, hot food or drinks, spicy food, emotional stress, alcohol, and sunlight. Recurrence of rosacea is common, and the disease may disappear spontaneously after a few years, but usually this disease is for lifetime. Some preventive measures can be taken for rosacea. These are marked reduction or elimination of alcohol, identify and avoid triggering factors, avoid using irritants such as soap or astringent cleansers, regular use of a broad spectrum sunscreen, topical application of metronidazole gel or cream in the formulation of 0.75% to 1% once or twice daily can be used, and systemic oral antibiotic can be used, and these are more effective than topical treatment. Minocycline or doxycycline 50 to 100 milligram per once a day or twice a day are the first line of antibiotic, and these are very effective. Tetracycline 1 to 1.5 gram per day in divided doses until the lesion is clear, then gradually decrease to once daily dose of 250 to 500 milligram. Metronidazole 500 milligram can also be given twice a day. The maintenance treatment of rosacea is minocycline or doxycycline 50 milligram per day of 50 milligram on alternate day, or 250 to 500 gram tetracycline. The use of isotretinoin is reserved for severe disease, especially stage 3, and the diseases that is not responding to antibiotic and topical treatment, because this isotretinoin has got very dangerous side effects. This is teratogenic also, and we have seen its side effect in detail in the video of acne. This can be given 0.5 milligram per kg body weight per day, and this is effective dose. Occasionally the dose can be increased to 1 milligram per kg per day, and the treatment is given for 3 to 9 months. Ivermectin can be given as a single dose of 12 milligram per orally in case of massive Demodex follicularum infestation. For the treatment of rhinophyma and telangiectasia, surgery, laser ablation surgery are educated once the inflammatory component has been treated. Beta blockers, carvedilol 6.5 milligram twice a day are also given for telangiectasia. They reduce erythema and telangiectasia. Intense pulse light therapy is given for erythema, telangiectasia, and papules every 3 weeks for an average of 7 treatment is given in a study, and it was effective to reduce the lesion in 70% of the patients.